So how exactly do we know that it's time to get rid of our disease-modifying therapy? How do we know that the MS medicine isn't working and it's time to kick it to the curb? In my opinion, there are 5 situations where we need to have a serious heart-to-heart about getting rid of your DMT, and I'm going to go through each one of them in this video. Now don't turn away, because that starts right now. Howdy, and thanks for learning about MS with me, Aaron Boster. Disease-modifying therapies, or the medicines that we use to slow down multiple sclerosis, are super important. In fact, it's my strong opinion that taking the most effective DMT that you're comfortable with and making sure that it's working is one of the key things to living your best life despite having this condition. DMTs are super important, but we don't marry them. We don't stay with them for life, for better or for worse. We only remain on the DMT as long as they're doing our bidding, as long as they're keeping our disease at bay. And so in reality, we are constantly reevaluating, is this medicine working? Are we getting what we want out of it? And if the answer is no, we need to pause and think about maybe making a switch. That's what I want to talk about in this video. 5 situations where I think we need to consider a switch of your disease-modifying therapy. Now, before we get into it, I'm not telling you that if you have one of these 5 things, you must change your therapy. I'm telling you that if you have one of these 5 things, we need to pause and we need to consider whether this is the best drug for you to remain on. You and your doctor will talk through it, and the answer might be yes, or the answer might be no. And so without further ado, let's jump in. Number 1 is having a breakthrough attack while taking the disease-modifying therapy. One of the things that we expect of a DMT is that it will prevent MS attacks or relapses. The platform injectable therapies like Copaxone, Avonex, Betaseron, Rebif, Extavia, Plegridy are moderately good at that. They can decrease an attack, say, 30% better than taking nothing. The newer therapies, though, particularly the monoclonal antibodies and some of the newer pills, are very, very effective at decreasing the risk of attack. Now, it's not 100% that you won't have an attack. These drugs aren't perfect, but we can have an expectation that you should not have attacks while taking them. I like to think about it this way. If you're taking a birth control pill and you get pregnant, it didn't work, right? Because the goal of a birth control pill is to prevent an unplanned pregnancy. If you have 3 children and you start birth control pills, you still have 3 children. They don't go away. You're on a birth control pill because you don't want an unplanned 4th child. If you have multiple sclerosis and you're taking a disease-modifying therapy and you're taking it the way you're supposed to, and you have a breakthrough attack, that's not okay, because the reason we're on the therapy is to prevent that from happening. Now, there's a couple, of course, important caveats. Medicines don't work instantly. MS medicines don't work instantly. So if you start a therapy and a month later or even 3 months later have an MS attack, we probably can't criticize that therapy yet. And so we have to be on the therapy long enough, and oftentimes that's somewhere between 6 months and a year before we can feel confident that it should be doing what it's supposed to do. I also want to highlight that if you're not taking your therapy regularly, then we can't really expect it to be effective. Now, that's not a criticism. If you're having trouble taking your medicine, that's not because you're a bad person, it's because it's hard to take it. And you should talk to your doctor. Say, hey, I really struggle to take this stuff, and as a result, sometimes I'm missing it. These are things that we want to game out. But number 1 is having an attack on the disease-modifying therapy. If that happens, we need to call into question whether this is the right drug for you. Now, oftentimes, at least in my clinic, we'll sort it out one of 2 ways. We'll either A, kick the drug to the curb and upgrade, or B, we'll put the drug on warning. We'll say, okay, you've had 1 attack, no more are allowed. If anything else happens, we're going to escalate to another therapy. And those are the 2 styles that typically my patients and I settle on when we have an attack on a drug. That's number 1. Hey, real quick before we go on, do me a favor. If you like this content, give this video a thumbs up, please. Also, if you haven't yet subscribed to the channel, please consider doing so. Those 2 actions teach the YouTube algorithm that you like this content and then help push it out so more people impacted by MS can benefit. Thank you. Number 2 is having breakthrough new or enlarged MRI lesions despite being on a disease-modifying therapy. A new MRI spot means the same thing to me as a clinical attack. Both of them are examples of breakthrough inflammation and represent brain damage, and they're not okay. And just like when I put you on a DMT, I expect you not to have attacks. When I put you on that same DMT, I expect you not to have new spots on your brain or spine MRI. I expect none of the old spots to get larger. I expect none of the spots to enhance. If I see breakthrough radiographic activity, so breakthrough MRI activity, while you're taking a therapy and you've been on it long enough and you're taking it the way you're supposed to, then that's a big concern for me. And just like if you had had an attack, if you had new spots on an MRI, we're going to hit pause. And in my clinic, we're going to either kick the drug to the curb or we're going to give it another shot. But I will typically get an MRI 6 months later. And if that MRI has new spots, now we're totally done. If that MRI is clean, I'll check an MRI 6 months after that. And if that has new spots, now we're completely done. If that's stable, I go back to normal once every year imaging. So number 2 are breakthrough lesions on an MRI despite taking your therapy. Number 3 has to do with your neurological examination. When you come into clinic, we do some form of exam. Sometimes we do that full EDSS thing. Sometimes we do functional testing. The point is we're tracking your physical functioning. And if we see that your testing scores are dropping, whether that be not doing as well on a traditional exam test, or whether that be that your speed of a particular qualitative test is dropping, that's a red flag. And if that happens while you're taking a disease-modifying therapy, that's reason for pause. Now, does that mean that we need to switch the therapy? I don't know, but we need to be talking about it. People impacted by MS can develop disability on their exam from one of 2 ways. One way we like to call RAW, or relapse-associated worsening, where you have an attack and lose a function and you don't regain it all the way back. Maybe you only recover part way. An example would be, God forbid, you're blind from optic neuritis, and when it heals, it only comes back to 20/200. Now you have accrued disability. That's relapse-associated worsening. The other way that your exam can get worse is called PIRA, progression independent from relapse activity. And this is where the individual gets worse, but they haven't had an attack. And people with MS, even early in their disease, can certainly get worse from both cases. My point is, as a screening tool, if I see that your exam's getting worse, we need to pause. We need to try our best to figure out why, and we need to ask ourselves the challenging question, is the disease-modifying therapy failing us? And might we fare better if we upgrade? Number 4 has to do with tolerability. We're asking you to take a therapy for the rest of your life to prevent your naughty autoreactive immune system from attacking the supercomputer that runs the body, the brain. And that's asking a lot of you. And sometimes a therapy, particularly over time, can become intolerable, and it can be really, really hard to do. And if the therapy is becoming harder and harder to tolerate, we need to talk about that. I'll give you a few examples. A long time ago, we used to only be able to offer people shots. And so we would prescribe an injection that you give yourself once a day or once a week or a couple times a week. And we had to try to be cheerleaders and talk patients into please jabbing themselves with needles. And it was really yucky. And doing it for a couple months is hard, and doing it for a year or 2 is hard. But when someone's being asked to do it for 10, 20 years, they can get what's called injection fatigue, which means it's becoming increasingly hard to jab themselves. And what we learned is, over time, people do their shots less and less on point. There was one really bothersome study that looked at interferon beta products, that's like Avonex and Rebif, and it looked at claims data, and it said that 2 years into taking therapy, only 40% of people were taking them exactly the way they were supposed to. The rest of the people weren't taking them as frequently. My point here is, if you're not tolerating your drug, as in this example I just gave, that doesn't mean bad you. No, that means that it's hard to take it. And if you're having trouble taking it, we should discuss that, because we might need to switch therapies because this therapy is no longer tolerable. The 5th reason that we would hit pause and consider switching off your therapy is if there are new safety concerns. So every drug has risk. And the risks are not static, they change over time. And so the risk benefit of a drug has to constantly be reevaluated. And a drug which was favorable at one point in time might over time become unfavorable. And I'll give you an example. A very powerful therapy called Tysabri, natalizumab, which is an IV in the vein taken once a month or once every 6 weeks. Tysabri has a rare risk of a very serious infection called PML. And if you are at risk because you've been exposed to the JC virus and you're taking Tysabri, that risk increases with subsequent Tysabri infusions. So the risk of the infection PML in the first year is very, 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 very low, like 0.001%. But over time, that risk can rise. And in some cases, let's say over 5 years, it might go up from 0.001% to 1%. And whereas 0.001% might be completely comfortable for you, 1% may not be. And so in this example, the safety profile of the drug changed over time. And when that safety profile is no longer in your favor, that's a legit reason to consider making a switch. If you've made it this far in the video, then I want to reward you with the sixth reason, a bonus reason. The sixth reason is if something better comes out. And so this has happened in my career. During the course of my career, we've had revolutions or transformations where we've had new drugs come out that are categorically better than the old ones. For example, the early drugs, the platform injections, are not good at slowing brain volume loss. They're just not very good at it. A lot of the newer therapies are amazing at it. And so there are patients where we were concerned about brain volume, where we switched because now there's something better on the table. And so a sixth reason why you might consider making a switch is because literally there are better options now on the table for you. One of the best ways that you can help this channel grow is by watching another video. If you'd like to continue to learn about how we can pick our disease-modifying therapy, click the playlist that's on your screen right now. Go ahead and click it. Until my next Monday morning video or my next monthly live stream, this is Aaron Boster saying be safe and take care.